Hi, everybody. Thanks for joining us. Just getting our slides organized, and Kevin's going to take it away.
Good afternoon, everybody. Gives me great pleasure to introduce our COVID conversation, understanding post-COVID-19 condition in Canada. And, I feel very honored to be able to host this session with Dr. Sarah Viehbeck. I'm an occupational hygienist. I'm not a medical doctor. So I'm going to introduce this session through the lens of an occupational hygienist. So in my introductory slide, I want to talk about why prevention is so important, and then lead you into Dr. Viehbeck's speech. Firstly, I want to start off with a land acknowledgement. I would like to begin by acknowledging that I am speaking from Ottawa, Canada, to all First Nations, Inuit and Métis people and their valuable past and present contributions to this land. As I am in Ottawa, I am located on the unceded territory of the Anishinaabe Algonquin Nation. And so at OCAD, we do actually reflect on different times in Canada, different dates in Canada. The other day we did actually have a session for the National Indigenous Peoples Day, and we were asked to kind of reflect on it and what it means to us personally. And we do have, if we think about the National Day for Truth and Reconciliation coming up on the 30th of September, I just want to talk quickly about Dr. Peter Bryce. So he was responsible for the health of Indigenous children in schools, and Bryce's report named poor ventilation and poor standards of care from school officials as his primary cause of death. Unfortunately, his report was never published, but he did produce something sometime after that. It was the story of a national crime. So, they found that roughly 1/4 of all Aboriginal children attending residential schools died of tuberculosis. And you think about him trying to alert the government about poor ventilation, it wasn't really listened to. I'd actually cycle out to Dr. Bryce's funeral, to his cemetery, so to his grave at Beechwood Cemetery. And that's just a picture of it there. And you can see that he's a hero, with the Indigenous people in Canada, and he has this modest little grave in the background there. I just want to talk about a recent report from Dr. David Michaels from the US, who headed up OSHA for some time, but he produced a couple of books. One was Doubt is Their Product, and the other one was the Triumph of Doubt. So he's actually, in this recent article, he said COVID-19 is an occupational disease that sickened and killed countless workers in healthcare and long-term care, animal processing, agriculture, warehousing, transportation, corrections, and other essential industries. Nonetheless, COVID-19 is rarely being treated or tracked as an occupational disease by public health agencies. So he's actually talking about the US here. The lessons from failure to protect workers during the COVID-19 pandemic can be helpful as the nation anticipates and prepares for the next public health emergency. I'm going to quickly go through these slides, but there is a lot of good information on the Government of Canada website that talks about the different outbreaks and where they occur. And you can actually go and see my slide deck. My slide deck will be posted, and you can actually refer back to this information. There's been a lot of discussion about hospital-acquired infections and nosocomial infections, and it's kind of quite controversial at the moment, with them dropping the mandates of mask in healthcare facilities. Just thinking about long COVID, we know that COVID-19 manifests as an acute and for many a chronic illness, according to Statistics Canada. As of October 2022, 1.4 million adults in Canada were experiencing long-term symptoms of COVID-19. the lingering complex symptoms experienced by a significant number of COVID-19 survivors weeks after infection, long COVID or post-COVID-19 condition. It's not a homogeneous disease. Individuals suffer from a wide spectrum of symptoms and conditions ranging from well-defined medical entities like hypertension and cardiac arrhythmia to broad or medically undefined symptoms such as cognitive problems. We all know that brain fog also can be caused by chemotherapy for cancer patients, exhaustion, chronic pain and fatigue. The impact of PCC goes beyond health. It also affects the ability to work and for daily tasks, creating considerable consequences for individuals and communities, as well as broader socio-economic impacts. In Canada, as in other countries, the healthcare system has been pushed beyond its limits by the pandemic. PCC stands to add further strain on the health system due to the increasing number of people requiring health access due to this new chronic condition. At the same time, a significant number of healthcare providers are experiencing a post-COVID condition, which complicates the system as they have difficulty performing their professional duties and seek healthcare themselves. We are all into this together. Pandemic management must address the health and socio-economic effects of SARS-CoV-2 infection as a continuum over time. So what can we do in workplaces to recognize, assess, and control the hazards that contribute to COVID-19 infection and prevent and mitigate the associated harm? I just want to talk about the importance of airborne or aerosol transmission. You know, this is just an article where Trish Greenhalgh and her fellow authors talked about evidence for, the airborne transmission. There's also a John Snow memorandum. This is a very good video that actually shows how, COVID-19 can float around the air like cigarette smoke. We did have Dr. Lisa Brossu present June 25th, 2020. Dr. Brossu is an expert in respiratory protective equipment and has a very good understanding of how the particles travel around in the air and how we can protect ourselves. We have, for some time, we've been providing webinars. This was a webinar, Conversations, Let's Hear the Engineers. Let's hear from the engineers and stop the spread. And John Udix provided a very good calculator on our website that we can use to do a ventilation assessment. There's also been information on surgical masks and respirators on understanding the difference. We've also been working closely with Dr. Simon Smith. He's the lead in the bioaerosols working group for the Canadian standard. And we do have a standard that actually can help determine what kind of respirators we need for both healthcare and non-healthcare. So the standard is cited in occupational health and safety regulations across Canada. Though is a legal requirement only in federally regulated workplaces in Manitoba. This standard was first published in 1982 and is updated periodically. It actually uses a control banding process. I just want to acknowledge Dr. Simon Smith for leading this out. There is also actually an online tool. You can actually use the tool to figure out what kind of respirator and what settings to use the respirator, the level of respiratory protective equipment. And just a couple of articles. This is an article here from Dr. Joe Vipond. He talked about, masks do work, but respirators much better, but distorting science to dispute the evidence does not. It's just an infographic to show that the surgical mask is not a respirator. The Lancet recently produced this document proposing non-infectious air delivery rates. So it was asking for much higher ventilation rate, and Dr. Joseph Allen, who's also presented through OCAO, was one of the lead authors in this. And recently, the ASHRAE group provided the control of infectious aerosols. So the intent is to approve a document by the end of June 2023, and this will be specifically for ventilation. There is a symposium happening at the moment in the US and there's some really great information there. I've just provided a hyperlink. You can go and you can look at the presentations there. There's also the Institute of Pandemics from the University of Toronto, and listening to it, improved air quality was featured a lot. And we also have close links in with the Ontario Society of Professional Engineers, and some very good guidance there around evidence-based guidance around indoor air quality and transmission of COVID-19. So over to the Government of Canada, PHAC. If you have a look at their website, they do have a hyperlink for improving indoor ventilation and also mask use. Now, I just want to introduce you to Dr. Sarah Viehbeck. She's the Chief Science Officer for the Public Health Agency of Canada. In this role, Dr. Sarah Viehbeck is responsible for providing strategic leadership to oversee and support science excellence, science policy integration, and science promotion, as well as, I'm just going to emphasize this word, re-energizing the scientific vision and capacity across the agency. Prior to this role, Sarah worked for 12 years at the Canadian Institutes of Health Research, most recently as an Associate Vice President. She holds her PhD in Health Studies from the University of Waterloo. It's a privilege to welcome you on board, Dr. Viehbeck, and thanks so much for providing your time. I'm sure you're very busy, and we all understand that you can only stay with us until 2:30. So I guess that's why I'm going to rush through my slides quickly so that I can give you enough time to speak. Over to you. Thanks again.
Thank you so much for that kind introduction, Kevin. I just had a moment. I can't believe I was actually at CIHR for 12 years, and I can't believe I've only been here for one, because it feels like longer. But I think that I say that in the best possible way. It's been a great year, and I'm really pleased to be here with you today. Thank you for your interest and for the kind invitation. I'm joining you this afternoon from Ottawa. I'm on the unceded, unsurrendered territory of the Algonquin Anishinaabe peoples. And it's really my pleasure to be joining you from these lands. I'm on a learning journey, as I believe we all likely are, around the history of the physical space that I live, work, and play on, as well as the contributions of First Nations, Inuit, and Métis communities to Canada, and the history in relation to First Nations, Inuit, and Métis peoples. And I take that responsibility very seriously, not only as a citizen, but also as a public servant, part of an institution that has its own legacy, which requires reconciliation. I'm also this month, just want to acknowledge Pride Month. I was at a Pride event earlier. I've got my Pride earrings still on. And I think that is a nice opportunity to celebrate love in all its forms. So I am here to speak with you today as a member of the Chief Science Advisor of Canada's Task Force on Post-COVID Condition. I'm really grateful to Dr. Niemer, who's our Chief Science Advisor for Canada, for convening that task force, and also for providing me with permission to use material from her office today, which synthesize and bring together the findings from that report. Je vais parler et présenter principalement en anglais aujourd'hui, mais je vous invite de participer dans la discussion ou de poser vos questions dans la langue officielle de votre choix. Et je serais très contente d'échanger avec vous en français ou en anglais. Alors, je vais essayer de faire marcher mes diapos. We'll see now. This is the part of the agenda where will the technology cooperate, and we'll hope for the best on that front. It was very smooth for Kevin. Can folks see that? It would be great if somebody could give a virtual or actual thumbs up.
It's coming across well, thank you. We can hear you very well as well, thanks.
Okay, thanks for confirmation on both of those very much. Thank you, and thanks for the virtual thumbs ups too. Okay, so what I'll do in my time with you is go over key findings from the Chief Science Advisor's report on post-COVID condition in Canada. Some of the report is really a synthesis that Dr. Niemer's office pulled together, but the recommendations of the report are from the task force overall. So I'll go through those. That includes latest scientific developments on post-COVID condition, and I'll also reflect and happy to discuss with you about the Public Health Agency's role within post-COVID condition, if that's something you'd like to cover in the discussion period. So I will, as I said, talk to you about post-COVID condition and also describe the key findings about the report. So what was the task force designed to do? Dr. Niemer has had a great history in her tenure as Chief Science Advisor of identifying and addressing through science issues of relevance to governments, ministers, and Canadians. And this report, I don't think, is any exception. The objective of the task force that she assembled, which was interjurisdictional, intersectoral, had the benefit of hearing from a number of contributors during round tables, both in terms of professionals from the healthcare sector, from international experts, given that this is not just a domestic problem, but a global one, from citizens that are experiencing post-COVID condition in their work and really that patient in their life and that patient experience of living with the condition, as well as from scientists working on this issue from across the full scope of laboratory all the way through to behavioral and social sciences. So the objective of the task force was to develop an evidence-based roadmap to provide a framework to manage post-COVID condition in Canada. It identified the evidence required as well as the data gaps to be filled. It provided recommendations for addressing the health and social economic impacts of PCC, which is the acronym I'll use to describe post-COVID conditions. So for short form, I'll say PCC in the Canadian context. We drew on data from, as I said, biomedical, biochemical, all the way through to socioeconomic research to inform the recommendations. And as I noted, it was a multidisciplinary panel with representatives from across sectors, but we also had the benefit of all of those roundtables and input from additional experts. I rarely put a slide up with my own picture on it. That's happened twice since this presentation has started. I'm sorry for that. But I'll just simply note that these are the task force members that are pictured here, and the roundtables, as I described, we're dealing with clinical research and practice, pathogenic and mechanistic pathways, socioeconomic impacts, health system impacts, the living and lived experience perspective with patients, and the international perspective. So let's start with first principles here. There are many definitions of post-COVID condition, and there are a number of papers which aim to synthesize those definitions as we sort out this new post-viral condition. But we adopted the WHO case definition for the purposes of guiding the task force's work. We didn't want to be too drawn in to a discussion about which definition to use, and so we selected the case definition from the World Health Organization. This is that post-COVID condition occurs in individuals that have a history of probable or confirmed SARS-CoV-2 infection, usually 3 months from the onset of COVID-19, with symptoms that last for at least 12 months, 2 months rather, and cannot be explained by an alternate diagnosis. This definition that we adopted was for adults. There are also definitions for children and adolescents that are being developed and perhaps were just released by the World Health Organization, developed through expert consensus. It refers to a whole variety of symptoms or clusters of symptoms after recovering from a SARS-CoV-2 infection. And you see on the slide here that we have symptomology occurring across multiple systems in our body, this is not an isolated condition or phenomena. It is generally multi-system and multi-symptomatic in nature. We heard from the patients that we spoke with that post-COVID condition is underappreciated in Canada. We heard the very real living experience of debilitating symptoms, which really impacted people's ability to work and to engage in day-to-day activities. We heard one individual say that they went from thriving to surviving. The majority of folks that we spoke with through the roundtable did not experience severe acute COVID-19 and had not been hospitalized. That's counter to the broader literature on post-COVID condition, I should note. We saw that there are many, in those that we spoke with, many working women with young children. They experienced stigma, misogyny, disbelief, lack of knowledge, inadequate support when navigating the health and social systems, including for disability insurance. And so I'm starting this presentation by that common grounding on what we mean by post-COVID condition, but also with reflecting that lived and living experience, because it is really powerful to consider what folks are experiencing with this condition, and also how much more there is to be understood. And we'll come in a little while to the important role of science and research within this picture. So what do we know? I think good to have a common grounding of the science. I should tell you that it is evolving, that we continue to lack common definitions that are well understood. The clinical diagnostic criteria have not yet been set or widely adopted, and there is no standardized diagnostic test for post-COVID condition at this time. It affects between 1/5 to 1 in 10 individuals infected with SARS-CoV-2. The Public Health Agency just did a survey at the national level, and we found prevalence rates, nationally representative prevalence rates among those that had experienced post-COVID condition of about 15%. So right in between these estimates. Post-COVID condition has variable symptoms, severity, and duration. They can get better and then return. So that episodic nature is consistent with the literature. Serious long-term health issues have resulted in people's ability to work, care for family in a subset of individuals. That goes back to those points around activities of daily living. The risk factors seem to include being a female sex, the severity of COVID-19, and having more than one SARS-CoV-2 infection. And there's still a lot more to be understood in this domain as we continue to figure out as a society how to live with COVID-19. While the public health emergency phase ended recently, as declared by the WHO, the World Health Organization, we can expect repeated infections to continue. And so how does that impact risk, I think remains a live area for research. We know that avoiding infection and reinfection is the best way to avoid post-COVID condition. We also know that vaccination prior to infection reduces the risk of developing post-COVID condition. And there's lots of research underway to understand the role of vaccination within PCC. And significant socioeconomic impacts do exist from this. The estimates within and across countries are significant. We know that the result is that it affects labor markets, gross domestic product, workplaces, social support programs, and additional health effects. And so this is a problem that has human, individual, all the way to organizational and societal impacts. We do still have a number of unknowns, and these are listed on the slides. We don't yet really understand the biological underpinnings of how the virus causes post-COVID condition, why symptoms, severity, and illness duration vary across individuals. We don't yet understand the gendered and sex-based analysis components to this, why women seem to be at increased risk. We don't understand why infection accelerates the risk of other chronic conditions and the intersects with diabetes and heart disease. We don't fully understand the impact of post-COVID condition on human development in children and in aging adults. That life course perspective is imperative. We don't understand the full extent of the labor and economic impact of post-COVID condition in Canada now and in the future. Similarly, the impacts on workforce productivity, the sectors most impacted, and of course, there are broader social impacts on areas like housing and food security. In terms of the socioeconomic impact in particular, I will note that the data here are definitely accruing and evolving. I mentioned that in an order of about 1 in 5 post-COVID condition patients experience that they're not able to work. Another 20 to 45% work reduced hours. This certainly impacts extended family and children. In the US, the most recent estimates of lost wages sits around $200 billion on an annual basis. And when you actually account for productivity losses and healthcare costs, you're seeing a doubling of that. Studies suggest racial and ethnic disparities, as well as a higher odds of post-COVID condition in marginalized communities. That's consistent with what we saw with the increased infection in many of those communities through the pandemic. So those disparities that may have been pre-existing persisted during COVID through infection, and we're seeing that then carry through for post-COVID condition. The economic burden could worsen over time. This would depend on the speed and availability and access to improved treatments, repeat infections and how that impacts risk, and the availability of vaccination to reduce risk or attenuate symptoms. So we see here the real breadth of impacts, and this is really a summary slide on what I've said already. We see the impacts cutting across sectors from health, labor, social, and economic considerations. So the task force put forward a 3-point framework for action with an overall vision to reduce the number of Canadians living with disabling long-term effects of SARS-CoV-2 infection and to limit the negative health and socio-economic impacts of post-COVID condition through enhanced services and supports. There were 3 components to this framework. One was around direct actions, really focusing in on clinical practice and research. The second was broader actions on socioeconomic policies and programs that may be of particular interest to this table. And then foundational actions on infrastructure and systems that include surveillance systems and science development. And I'll speak to these in turn. This is probably entirely unreadable, and I'm sorry about that. I'll go through it very quickly. It really reflects what I clustered around those 3 areas of the framework. So the first cluster of activities is around direct actions. So you won't be surprised to hear me say this based on what I covered earlier in the presentation. First recommendation is establishing clear diagnostic criteria, standardized assessments, and clinical practice guidelines based on common definitions. And on a positive note, I'll just share that the Public Health Agency of Canada has made an investment in work to develop clinical practice guidelines. This work is being led by Holger Schoenman at McMaster University and is being supported over the next several years. So I'm optimistic that this will be addressed. And I'll also point folks to recent literature by Angela Chung and Kieran Quinn within the Canadian Medical Association Journal, which I highlight some thinking around diagnostic criteria. The second related component is establishing post-COVID condition diagnostic codes. Third is around equitable access to person-centered care pathways. The fourth is around developing a long-term integrated research strategy for infection-associated chronic conditions, including post-COVID condition. We know that infections often result in post-infection outcomes, and post-COVID condition is one, but there are others that may need to be looked at, and so an overall research strategy there is needed. Fifth, putting in place a Canada-wide research and clinical care network for post-COVID condition and other similar post-infection chronic conditions. And again, with a hint of optimism, I'll note that CIHR, the Canadian Institutes of Health Research, has invested just at the end of 2022, $20 million in establishing a 5-year-long research network in post-COVID condition. And that's being led by Dr. Angela Chung at the University Health Network, with colleagues from across the country. It's very integrated and multi-focused network that covers everything from biomedical through to clinical, economic, and social impacts. And then lastly, within the direct actions, advancing 5 targeted priority research areas. In terms of the broad actions, this is around updating relevant policies and eligibility criteria. This is really about eligibility for benefits. 8, developing resources and tools that respond to the needs of people living with post-COVID condition. raising awareness through outreach, developing and continuously updating a web-based platform that lists available government services. And Kevin, really appreciate your referencing the Public Health Agency's website. Of course, within jurisdictions across Canada, there's also health information available that's tailored to the province or territory in which folks live. Developing and implementing educational approaches for healthcare providers. That, of course, ties very closely to the development of standardized assessment, diagnostic criteria, and clinical practice guidelines that I mentioned earlier. And empowering Canadians to make informed decisions about the prevention of SARS-CoV-2 infections. And in terms of the last cluster, which is around foundational actions, the first area here is around establishing a scientific advisory council on infection-associated chronic conditions in collaboration with Dr. Niemer's office, providing a whole of government coordination structure within the health portfolio. The Public Health Agency is pleased to be leading that work, and we work in collaboration with a number of departments federally to be able to each work on our respective piece, but as part of a coherent whole. Enhancing the timely capture and sharing of data and the use of state-of-the-art data analysis strategies. I spoke at the outset of the presentation about emerging surveillance information around the proportion of Canadians impacted, the nature of symptomology. That was a survey that Public Health Agency of Canada co-sponsored with Statistics Canada and the COVID Immunity Task Force, and we are repeating that survey this year ahead. And the last recommendations really relate to strengthening the infrastructure that interconnects and supports research, care, and emergency preparedness, scaling up and monitoring effective prevention interventions, including improved ventilation, and encouraging innovation in post-COVID condition care models, including healthcare workforce recruitment and retention, which are issues not limited, of course, to post-COVID condition, but do need to be considered as part of the response. So I believe that I've shared that post-COVID condition is a complex global challenge. I'm highlighting here just a very recent data from 2023. Data are coming out every single day on this issue. And so really lots to watch, as I noted at the outset, around the evolving nature of science and action in this space. So I'll close by noting that we have, I think, found through the task force's work that post-COVID condition carries significant health and economic burdens, which merit being addressed. This is going to have to happen multi-sectorally and multi-jurisdictionally. Prevention continues to be important. Diagnostic criteria and treatment are required. Effective management of post-COVID condition and access to care correspondingly requires robust data collection as well as interconnected care and research within living healthcare systems. Long-term investments in research and related platforms are required, and we know that this will not be the last pandemic. And so we need to consider the long-term and broad chronic effects of pandemic and other health crises as integral components to emergency preparedness and response. And certainly we're doing that at the Public Health Agency of Canada. There are a number of studies which continue to support the recommendation, which I've listed here, and you can consult those as you like. So I will stop presenting and would be very pleased to have a discussion and hear reflections from your roles as participants, as practitioners, as leaders within the occupational health and safety space, and would be really pleased to discuss with you. Thank you.
Thanks so much, Dr. Viehbeck, and thank you for leaving time for questions, because we wanted to try and make this a bit more conversational as well, but it's really nice that you've framed it this way. Before I go to the chat feature here, I just want to ask a question myself. You know, I'm an occupational hygienist and I work closely with other occupational hygienists. And actually, since the pandemic started, we also work closely with professional engineers. And I'm not sure if this is kind of in your area of responsibility, but the table that you presented, the framework for actions, and I see on it's item number 17, where it talks about scale up and monitor effective prevention, including improved ventilation. So I'm just wondering whether you might want to comment on the interdisciplinary approach in PHAC, and whether occupational hygienists and professional engineers and perhaps, respiratory protection experts actually feed into the strategy and help develop the guidance. I'm just sure if I can ask you that first, and then I'll go to others. Thank you.
Sure. Thanks very much, Kevin. And yes, ventilation did come up within the context of good practices around prevention. The specific recommendations look at improving ventilation in schools, workplaces, and public places as part of that first line of prevention of SARS-CoV-2 infection and other respiratory or airborne pathogens. Of course, this requires interdisciplinary approaches, and the expertise there comes from research funded through the Natural Sciences and Engineering Research Council, work happening at the National Research Council on guidelines and guidance, as well as innovation. And so it is interdepartmental. It's also interdisciplinary, as you rightly point out.
Great, thanks. And I might just refer to one of the questions in the chat. So Dr. Lynn Filter is a retired emergency doctor. I'm also part of a working group, aerosols working group with Dr. Simon Smith on the Canadian standard. And we were kind of keen to know why this Canadian standard for respiratory protection wasn't adopted across all provinces in Canada. It is federally, and I think in Manitoba, but in its entirety, it wasn't actually fully applied. But I just want to refer to the question by Dr. Filter, and Lynn, you might want to show yourself and ask the question directly to Sarah, if you don't mind. That saves me repeating your question. Would you mind showing yourself and asking the question? Thanks.
Yeah, sorry, somebody's mowing the grass, so you may hear more of that. So my question had to do with the what we're seeing unfold with the NIH and the funding for Recover. There doesn't seem to be a lot of accountability or supervision in terms of, are we getting bang for research money? And one example was the money targeting studying exercise in the role of treatment of long COVID. Meanwhile, we know that graded exercise is actually makes many people with long COVID worse because of post-exertional malaise. So how do we make sure that the money we have, may sound like a lot, but we know it's not, really gives us the most information to take care of people who have long COVID?
It's a great question, and one which probably would be best answered by my colleagues, the Canadian Institutes of Health Research. But I can reflect that having heard Dr. Chung speak, Dr. Chung is leading Long COVID Web, which I mentioned very briefly. This is a large-scale multidisciplinary, multi-sectoral, multi-jurisdictional network looking at research on post-COVID condition. It's spanning from biomedical laboratory research through to clinical research, through to health services systems and public health. And she is certainly speaking about the need to have ongoing priority setting mechanisms so that the research is well aligned with the needs of those that it's intended to serve. There are reporting requirements for that research, which are in place by the funder. And it seems like because it has a multi-year horizon, that there will be opportunities to adapt based on what they're learning from emerging findings. I'll probably leave it there, Lynn, but you're raising, of course, a really important question around the return on investment in science. And I'm sure that colleagues from CIHR would have many interesting things to say about that.
Thanks, Lynn. Thanks, Sarah. So I'll just work down the chat here. It would be good to get through all these questions. So maybe what I do, Dorothy, I might ask you to show yourself and ask the question, but if we can kind of keep it reasonably brief so that we can get through all of them, that would be great. Thanks.
Yeah, so thanks for the presentation. I'm sorry, I haven't seen the document, so but I did want to bring up two things. One is, where does the reality of airborne and aerosol transmission fit in the prevention recommendations? So I know you've mentioned ventilation, but people need to know why they need it. So if transmission isn't explained properly in terms of prevention, we're not likely to get people paying as much attention as they should to whether it's respirators or ventilation or other things. And then my other question had to do with sort of what are the specifics for workplaces or jobs, because that's certainly been a too important or a very important source of transmission in this pandemic.
Thanks very much, Dorothy, and really good question. The slides that I presented, I think it's just important to remind folks, are on behalf of the Chief Science Advisor. So I've not given a sort of overview around the public health agency's role in all of this. I see some comments in the chat about, the concerns of public health agency, et cetera. I just want to be clear that the slides that I presented were on Dr. Niemer's behalf. And of course, I was a member of the task force and was happy to be. In terms of your question around ventilation and airborne transmission, the report and the scope of the report did not go in to a lot of detail there, but the Chief Science Advisor had earlier published a report, which I'm happy to put in the chat, around bioaerosols and indoor ventilation and COVID-19. So I'm happy to put that into the chat because that was referenced, but did not go into detail through the scope of this particular report. In terms of your question around workplaces, really important and not surprising given this audience. So there were a few things that came up there. The first was around looking at potential benefits for non-pharmacological treatments, like needing to rest during your acute COVID infection phase, and we need much more information on how those measures may help or impact post-COVID condition. The results of that could, of course, impact health, but also workplace guidelines, and so that's one thing that's observed within the report. The other is around potential adaptations that may be needed. So the report notes that as the evidence is really evolving on post-COVID condition, we need modeling projections in place to actually determine how many Canadians are likely to be impacted by post-COVID condition in the coming years, and how to best adapt schools, workplaces, social supports, and the healthcare system to support these individuals and their dependents. So there are some other comments about workplaces throughout the report, the importance of needing to have tailored communication approaches, for example, is there, and the need for outreach through citizen schools and workplaces as a mechanism to reach folks is also articulated. On the public awareness recommendation, which is really about outreach to schools and citizens and workplaces, the recommendations there are about developing consistent and culturally sensitive messages in partnership with patients and community groups, providing public education on the risks of post-COVID condition and the importance of tools for preventing it, providing proactive outreach and education to help people living with post-COVID condition make informed decisions, and to follow communication campaigns on post-COVID condition with public health activity around vaccination and other relevant public health measures. So that gives you a sense of where that recommendation that's specific to workplaces is situated. I hope that helps.
If I could just add to that, this whole thing about transmission, or as I sometimes call it, transmission truth, is really important. If people don't get that, then they don't understand the importance of the measures that can be taken, including respirators, not just ventilation, but respirators, which is in some ways your own personal little ventilation system. So it's really, if you don't have that as a grounding, I think that people don't get it, that these measures may be needed. And the other thing that, just in terms of workplaces, two things. One is, as some of us have been reminding people throughout this pandemic, schools are workplaces. So they're, and sometimes people put healthcare in a different category than workplaces. So there's a lot of places that where people work. And I work on projects with migrant farm workers. And I think that that's one of the really important kinds of jobs that really need to be taken into account when folks are looking at this. And the repercussions for those folks are in some ways a whole lot worse, at least in terms of their jobs, than for folks who may not live here year round.
Thanks for both of those points, Dorothy, really well taken. And just want to acknowledge that in the chat, there was a question around who is leading the development of the clinical practice guidelines based at McMaster. My colleague Corey has put a link to the guidelines into the chat, and it's Dr. Holger Schoenman who is leading that work. And you can check that out there. I'll also put the link in the chat to the Long COVID Web, which is the CIHR funded research network led by Dr. Chung. And folks can check out their website as well. Thanks.
Thanks, Sarah. And I'm going to refer back to Dr. Filtro too again. Lynn has an interesting story. She was actually in the hospital when SARS broke out in BC. So, you know, if you want to find out a bit more about, you know, how it was managed and how it was contained, Lynn can sort of share that story. But she does have a point here that there is actually, Lynn, you're showing yourself again, so why don't you ask the question?
I'm actually going to do a double whammy. Until we get to the shared scientific knowledge of how the virus spread, and until we accept that the effects of the virus don't stop at 30 days, we have no hope in hell. And federal public health, so public health agency, has been a leader. However, those who manage the response are the public health at the provincial territory level. So my question, there's two questions. One is, we know from New Brunswick FOI that the Office of the Chief Science Advisor had been sending information about long COVID on a monthly, then a bi-monthly fashion since at least June of 2020, after the long COVID community in Canada sent a heartbreaking letter that they weren't getting better. And I live in a province where long COVID is being minimized, is being disregarded, it's not being talked about. And I live in a province, like many others on the call, where we're still washing hands and washing surfaces. And to make matters worse, we have removed every possible mitigations in healthcare right now and long-term care. And we're not looking at the impact. So I think what Dorothy was getting at is we're at the point where we're looking at the feds to really go around and educate the public, because that is being failed right now. If we keep letting provinces run the show and don't educate the public that this is serious, that long COVID is real, that it spreads by the air you share, and that you better mask work better, we're going to fail. So your first point was limit the number of people that get long COVID, and you cannot do that unless people understand how this virus spread, and you can't do that without people hearing that long COVID is real. So that's where I'm going, and I'm sorry to dump this on you, but that's really what the crux of the matter is right now. And if we look, I'll go one step further. If we look at what's happening in Australia right now, in Chile, in Brazil, we are on track of having another triple-demic start September or earlier. So we really need to get this spreads through shared air. And it's not just COVID, it's RSV, it's influenza. We had 6 children dying of influenza this year in British Columbia.
Thanks, Lynn. And you know, I just think we're all learning together here. We're sharing our learning, and we're trying to understand the situation. I too have seen the disconnect between PHAC and what's happening in the provinces, and I think it's a really important point. And I know a lot of that's outside of your control, Sarah. But I don't know if you if you can have you any comments on that disconnect and how the great information and guidance that you're sharing and leadership can actually translate to a provincial level, because it's something that we're all kind of dealing with locally. Thanks. Thanks, Lynn.
I don't have anything to add, Kevin. Thanks. Thanks to you and Lynn.
You know, one of the things, Sarah, that could be done is really pushing the advertisement, looking at what Jon Snow has done, and the feds have the budget, and put out the Jon Snow advertisement and blast it everywhere. Because right now it's like we're living in a zombie world. I just got back from Quebec, and I can tell you I'm the oddball in my family that is masking everywhere I go. And I'm the only physician, and they're not listening to me. So we need really the feds to either use media, use what Jon Snow has done, and blast it out that long COVID is real. You know, put N bearer and do an advertisement. Use the people that are suffering to share their story, because right now we're on track of, you know, we're just keep doing this, what we're doing, and there's going to be no healthcare soon.
I just, yeah, thanks, Lynn. Just, there's another question here from Stacey to everyone. I would like to ask a question about the recommendations from the Chief Science Advisor for post-COVID condition regarding infections, reinfections. Did you want to take that on? We know that reinfections, you know, increase the risk for long COVID, but I don't know if you have anything to add to that, Dr. Viehbeck.
Stacey, could I invite you to come on just to say a little bit more about your interest, if you feel comfortable doing so. Oh, there you are. It's really helpful to get to see, you know, Lynn and Dorothy, Kevin, and now you, Stacey. Thanks for that. Go ahead, please, and happy to try to help with this one for sure.
Yeah, I know that the report that came out on post-COVID condition and hi, Lynn, I haven't seen you in a little while. So the report that came out from the Chief Science Advisor regarding post-COVID condition specifically says in the recommendations, the best way to avoid post-COVID condition is to avoid infection. And knowing what we know and knowing the high prevalence of the virus right now through wastewater levels and through people that are, or organizations that are trying to track as much as they can, it makes it really hard because I have post-COVID condition. I'm going on, I guess, 3.5 years, and I've unfortunately had 2 reinfections, and each reinfection set me back drastically. We know that. Everybody knows that reinfections are negative for someone whose body we already know is reacting in this way. And I'm not saying that everybody's bodies won't react the same way as they continue to get reinfected, but my issue, and I think what is the responsibility other than giving information for the office of the Chief Science Advisor for Canada? Because I mean, as Lynn mentioned earlier, we had bi-weekly and monthly reports being sent from Public Health Agency of Canada and the Office of the Chief Science Advisor for Canada for close to 2 years before any provincial government talked about post-COVID conditions. I've spoken to my MHA regarding my situations that I was going through when Canada, the federal government, was saying that post-COVID condition is the thing. Meanwhile, we have there's no trickle down to general practitioners or family physicians regarding information of post-COVID condition, what to look for, what to test for, keeping an eye out on certain things. And then for mask mandates in healthcare settings to be dropped without this education even being sent to provincial governments, or, well, it's being sent to provincial governments, but not being sent to the actual health authorities to give that information to their employees. So these employees have no knowledge of what post-COVID condition is. I go for, I'm asking for accommodations now because I'm trying to explain that I have post-COVID condition, and I've recently got diagnosed with an immune deficiency as well on top of this. So I'm finding myself having to explain myself to health practitioners because of that knowledge gap. And as Lynn said, I don't feel that anything will happen until there is an education campaign, and it needs to come from the Canadian government, because provincial governments are omitting information that they are aware of and not sharing it with the proper health authorities. So people are just not getting that information. It's all there. It's been here for a very long time. And I feel that, well, after they dropped the mask mandate in Newfoundland and Labrador, I called OHS for the provincial government, and I was forwarded on to one of the lead people with IPHAC in the province. And I had an in-depth conversation, about an hour and a half. And she still does not think that COVID is airborne. She still thinks that it's droplet. And she said, well, it's sometimes aerosolized. And I said, no, it is. I mean, it's aerosolized when you speak. It's aerosolized when you sing. It's, that basic information gap with people that are running our hospitals. There needs to be a top-down information campaign, because these people are making decisions for everybody's health based on information that is completely inaccurate and not up to date. So I just, that's what I wanted to pipe in, because I know Lynn did mention that the reports that had been coming from Public Health Agency and the Office of the Chief Science Advisor, they're just not being relayed. And I don't know who is responsible for that information gap. And I know each province has its own health authorities. So in the past, things like when mandates did come into place, or health precautions, I should say, I don't like calling them mandates. When these health precautions were in place, they were recommended federally first, I believe, through meetings. So why aren't those meetings occurring? And meetings like this are people at the provincial levels being invited to come to this and refusing invitation? Because I know there have been multiple pan-Canadian meets on post-COVID conditions since this has started, and I'm just wondering, what is the responsibility, and at what point does it become negligence instead of ignorance? Because claiming you don't know anything is one thing, but once you turn down the information multiple times, then it's negligence. So that's just what I wanted to pipe up with, because with post-COVID
Stacey, I'm just a bit mindful. Sarah's here until 2:30, and people are welcome to stay, and we can have this conversation after. And it's, public engagement is so important for sure, and I think that's the message here. It is 2:30, Sarah, and I see Gabriel's got his hand up. Would you mind sparing just one more minute to answer Gabriel, or do you have to pull away directly now?
I'm really, really sorry, colleagues. I do have a hard stop due to another meeting, but I really appreciate the invitation to have been with you today on behalf of Dr. Niemer. It's great to see so much interest and commitment to this issue. And I just want to acknowledge, Stacey, thank you for sharing your personal experience with post-COVID condition. I know that can be difficult to talk about. So thank you for that as well. And for your questions and engagement. I really appreciate it. Kevin, thank you. And I'm sorry I can't stay longer.
Thanks so much for your time. We really appreciate it.
I know.
Thanks. And yeah, we're going to stay on longer, everybody, if you want to ask. So, Gabriel, did you want to ask the question to the people that are here now, or did you want to raise something? Your hand's still up, or your hand's up.
Yes, I just wanted to comment further on Dr. Phil's comments and yours, Kevin, about multidisciplinary assessment and, of course, airborne transmission. We've known since SARS, I mean, probably before SARS as well, certainly in the physical sciences, that coronaviruses are airborne transmission. Whether there are other means of transmission, doesn't matter. It's primarily airborne. We've known this since SARS. It's in the SARS Commission reports. I testified there, orally written, so did many other people. We talked about the hospital situations at the time, about so-called isolation rooms that were never proper isolation rooms, et cetera, et cetera. All of this was known 20 years ago. Now it's 20 years ago. There was a comprehensive Campbell report, and to this day it's collecting dust. And there's still no quote unquote multidisciplinary, I won't even list all the people and all the different areas that would come in multidiscipline, but even a simple one, such as the Ministry of Health, one of their main recommendations, Ministry of Health and Ministry of Labor and Occupational Health as an umbrella with everything that it entails, should be cooperating in developing policies, regulations, etc. None of that has been done. It didn't happen this time either. The Ministry of, we talked about labor transmission in the workplace, which is very significant. Maybe the only one higher than that on a population basis is transmission at home once somebody got infected. And this recent COVID epidemic, the Ministry of Health and the Ministry, when was the last time anybody ever heard from the Ministry of Labor regarding airborne transmission? I personally was involved with some of the abattoirs out west. I told them on day one, before the official recognition of transmission came out, I said, okay, you're not going to ventilate, air condition, rectify an abattoir, but deal with the washrooms, the restrooms, and what to do for ventilation there, up to and including toilet covers, outdoor ventilation of the washrooms, etc. The eating areas, and those places that just adopted Mickey Mouse suggestions from me, stopped there significantly their airborne transmission and continue to.
Sorry, Gabriel. I think what you're doing is.
I don't want to carry on. I'm saying
you're
we have
preaching to the choir, and do you have a question or a comment?
The only comment I would conclude is we have to lobby governments. We need regulations. All these guidelines that have come out for years and years in this area and any other areas of medicine and hygiene, we've got recommendations and guidelines and nothing happens. We need to lobby.
Yeah, I think that's
regulations.
We're trying to share the knowledge and the evidence, and just through these webinars. So, you know, through these webinars, hopefully, you know, the message will get through. And just looking at the chat box, somebody did say that, you know, really, the Public Health Ontario and the Chief Medical Officer of Health, you know, they're in control. So the ministry has to follow their guidance, and unless things have changed there, that's the way it's been. So it's, yeah, I think that's why we're doing these webinars, to, you know, to talk about the evidence and to raise awareness. Did you have anything to say, Val? Like, did you have any thoughts that you want to share?
No, and I appreciate, Gabor, your, you know, voicing the frustration we all feel, we continue to feel. And as we've been feeling for 3.5 years, it is actually almost the 3rd anniversary, I guess, which is since we started this series in June of 2020. And we never anticipated at that time we would still be talking about it, and even more frustrated and more afraid than we were back then. Back then we were, you know, what's happening, that we were confident. We had the SARS Commission, we understood aerosol transmission. If only we could get it recognized, we could make a difference. So I think we're all still reeling and trying to deal with that, and and avoid the complacency and fatalism that seems to be even in Dr. Viehbeck's comments. I mean, of course, they're about the report and they're about the, they're trying to, and acknowledge, you know, there's one line in there that says prevention is the best way. Preventing COVID is the best way to prevent long COVID, which that's most of us would accept mathematically. But that it almost seems like there's nothing we can do and we're just going to have to learn to live with it, which is not going to be good, as Lynn has said already, right? It's so we're trying with these small events like we're doing, and then we have them online, and we try to influence where we can, and try to make people aware that the risk is still there. Fortunately, somewhat reduced at this time. If you can be outside and avoid breathing the other people's air indoors, then it's a time that we can maybe have more fellowship and things like that. But as Lynn has said, we are watching Australia, and we want to see what we can learn from that, sadly, to try and influence things more. So this is a lull over the summer. What can all of us do? And I'd be interested in, you know, people turning on their mics and their cameras. What else more can we do to influence things, given the challenges that we face and the complacency, and I think the fear, not just of being proven wrong, but so many people have been infected. Nobody wants to think that that could happen to them. So there's a natural mechanism there, but and particularly what can we do in workplaces. So I'll stop talking because actually we're here to, you know, it's a conversation. So Lynn,
and I think also we need to look at what's happening south of the border, you know, looking at the symposium that's happening at the moment, you know, 2-day symposium, a lot of great information's being shared there. So it's up to all of us to, you know, keep abreast of the latest evidence and science. And I just thought I'd put this out there, like, you know, Val or myself or many others are medical doctors, and this is about long COVID. And I see Dr. Leon Genisov's in the audience, and you know, if you're willing, Dr. Genisov, I don't know if you mind sharing some of your thoughts with us as well, if that's at all possible.
Thank you. I think we've reviewed lots of material. There is a lot of material available about post-COVID syndrome, and I think we're correct in that it isn't trickling down to the proper places, and we have to assist with the dissemination of that information. So why that is and how that can be taken care of, that I can't quite speak to, but as mentioned, I mean, these are very well-known phenomena in terms of prevention, investigation, management, and the ubiquitousness of post-COVID condition. So, you know, it's a constant effort to ensure that information is disseminated appropriately. We see a lot of information that's been developed in Canada and Ontario from McMaster, even from related agencies in Ontario. Ontario Health has developed some information, but somehow that has to be disseminated. So either it comes from, as in the cases of some of the personal experiences here, from the ground up, from the patient up, which is a bit more difficult, or from the top down, which is a bit more appropriate. And that's, whoops, there. But so that's, I mean, that's the situation. So exactly how to improve that, I'm not quite sure. In terms of interactions between agencies, so in many cases, there's a variable impact. So sometimes it works and sometimes it doesn't, and how to keep that going. I think the Campbell Commission talked about that. And again, it's requires constant energy to ensure that gets through. So again, I think this is what, if I can be positive, I think, you know, this is one of OCAL's, at least in Ontario, one of their main goals is to support and disseminate this information like they're doing now, and being very positive about it, and trying to disseminate to that wider audience. That's all I can say. Thank you.
Thanks, Leon. It's good to hear your voice, your perspective.
On me?
Kevin, you're muted.
Can you make me another one, please?
Sorry about that. I just, just thanks so much, Dr. Geneso. We really appreciate your input.
Yeah.
And if you're not speaking, I'm just wondering if you can mute, if you can hear us, because there's some interference coming over. Somebody's, we're hearing somebody else. Heather, to everyone also, she's talking about following up with what Stacey said. It's kind of this old point of care risk assessment issue again, and you know, if they are not informed that SARS is airborne by their IPHAC ID committees, they will fail to undertake an adequate risk assessment. And if you look at the Canadian standard for respiratory protective equipment, you have to understand what the ventilation is to determine what kind of respirator you use in a healthcare setting. So it's very difficult, you know, point of care risk assessment for people to know what that what kind of respirator they should use. So I think there's a lot of work to do there still about that frontline risk assessment. So that's a very good point. Heather, is that what you were, did you want to add to that at all? Like, did you want to show yourself and add to that discussion?
So briefly, I'm an epidemiologist and a human biologist. I'm not a physician or an infectious disease person myself. I'm just a concerned citizen who's also advocating on behalf of safe schools. Not so much the healthcare setting, but I'm aware of the rulings in Ontario, at least with the nurses, that they wanted access to N95s, as far as I understand it, and what ended up happening was some directives were changed, and it came down to the fact that the judge was happy that they would be allowed to access N95s if they made a point of care risk assessment that there was an aerosolized threat. And I think that that's entirely problematic. That doesn't acknowledge the airborne threat of COVID. Number one, just basic. It didn't acknowledge the fact that it's spread by airborne mechanisms, and then it didn't seem like the actual information about the aerosol or airborne threat even was shared with healthcare workers or education workers or any workers. So how can you make a point of care risk assessment if you don't have the information and you don't understand what the risk is? And so if they're not being told what the risk is, then also there's that secondary problem where people trust healthcare workers to know more about health. And you expect that the nurses and doctors in your life are going to know more about how things spread and how concerned they should be about it. And so that's another, that's a secondary problem to that, to the information about long COVID and about the means of transmission of COVID or of SARS-CoV-2, not that information not getting out to healthcare workers. So one, they're not able to protect themselves adequately, and then two, they're also potentially then spreading misinformation and acting in ways that embolden people around them to also not be taking enough precautions. So those are my comments.
Great discussion, thanks. And I'm just noticing in the chat, Lynn Scott, with point of care risk assessment, you think about 50% of people being asymptomatic. So it's very hard to kind of figure out whether there's a risk or not, because people are transmitting the virus and might not even know. It's a good point, Lynn. And your comment about circulating even the John Snow memo and that video talking about airborne transmission widely. There's just so much education that has to happen to make people aware that COVID is airborne, and there's future infectious diseases that are airborne. It's just a very important time to do that now. Yeah, I think that's probably it. Unless we've got about 15 minutes to go. I think we've kind of worked through a lot of the questions. We've had a few people speak. I'm pretty sure we'll have this chat saved, and then we can hopefully somehow share it. And I see that Dorothy even suggested we try and share some of this information with Sarah as well. But just with we've still got some time. We've left this open till 3 o'clock. Is there anybody else with any kind of burning issues or things that haven't been brought out on the table? My slides will be posted, and there is a hyperlink to the Institute of Pandemics webinar that was recently held, and also the link to the National Science Academy in the US. Apparently they're posting all their slides on their website. So I've got a hyperlink in my slide deck to that as well. And they do talk about symptoms and which symptoms do you narrow down and how many symptoms there are. It's kind of quite it really does open your mind with long COVID, how broad this is, and even the other diseases that can perpetuate from it, such as induced postural orthostatic tachycardia syndrome, otherwise known as POTS. And what the webinar was saying was that this is quite common now, that people will see this a lot more.
Yeah.
You'll see that there's going to be a lot more information shared from that. So were you going to say something there, Lee?
Yeah, I just want to speak to the group. I think the time to be nice is done. Like, we're beyond that. And I think right now what we have is we have a federal versus provincial dichotomy. The feds get it. They have no power over healthcare, very little. So, but they have funding. So I think sending the links to the New Brunswick FOI, sending the link that I put in the chat to Stacy with a clear ask that at some point, if it's true that they want to do prevention, it starts by acknowledging how this thing spread, and it starts by acknowledging that long COVID is real. And we have to bypass provincial government and public health. There's no way around. If they haven't gotten it by now, they're not going to get it. So I think we need the feds to blast media, blast radio, and get the word out. Because as much as I'd like with OCal and what we're doing with POP BC, we're not reaching the masses. We're not. We're preaching to the converted.
Thanks, Lynn. And I see Leon's got his hand up again. And, there is also that kind of, the kind of dichotomy, the barrier between, public health, the Ministry of Health, and also the Ministry of Labour. Also, in Ontario, the inspectors going into workplaces can't really issue orders because, the Ministry of Health and, public health seem to rule the roost. But you've got your hand up, Leon. There.
So I just I left the Ministry of Labor just before COVID. But what I was going to comment on, I think, Lynn mentioned this, is in terms of getting information out. So in terms of, most people, in terms of members of the public, even in the healthcare professions also, but most members of the public don't understand methods of transmission and issues around that. And I think for me and my dealings, as I work in public health during COVID, is it's important to emphasize the consequences of COVID and what people are trying to prevent, whether it be post-COVID syndrome, fatalities from COVID in many situations. And you look at the long-term care homes and other settings, even family settings, when no precautions were being taken, and you had this sort of school, home, long-term care cycle. It's very important to emphasize the consequences of transmission. And Kevin, you outlined some of the other syndromes besides post-COVID syndrome, but those and the real morbidity and mortality from COVID. And people, in my experience, don't quite understand the consequences of COVID. And I think that has to be emphasized also. And, maybe that'll help stimulate some of the prevention programs.
Thanks, Leon. If you listen to the Institute of Pandemics webinar, you listen to Dr. David Fissman talk, like he doesn't really mince words, he goes straight to the chase. And he's got a great way of communicating those sort of messages in simple language as well. So, yeah, it's really important that people understand what the consequences are, for sure. So, Gabor, you've got your hand up again. Do you want to share your thoughts?
Yes, Heather, I'm sorry, I don't know your last name. She talked to the fact about doctors and nurses and healthcare professionals, etc. One key point I want to make is doctors, healthcare professionals, period, nurses, are not the ones we should be going to. And by we, I mean the government and everybody else when it comes to transmission. You heard on ad infinitum from Fauci on down to our local media interviewing infectious disease doctors ad infinitum, usually the same ones, the ones they disagreed with, they never called back. These are not the people who know about transmission. With all due respect, I'm a physician. If I get some strange bug in me, yes, I want an infectious disease person. How to prevent that strange bug from getting into me, that's not his domain. I say we sometimes because I'm an engineer too. Those in the physical sciences, in those separate silos, AIHA, the various industrial associations, the HVAC groups, we're all in different silos. Somehow we got to get to the table. This was mentioned, the multidisciplinary, which has been mentioned at least since the Campbell Commission. Doctors can treat disease. They're not the greatest, and in most cases have no real expertise at all when it comes to and if they know anything about how it's transmitted, they know even less about how to prevent that transmission. I mean, social distancing, these are platitudes. And even if you do hunker in your basement for the next 6 months, sooner or later you got to come out. Doctors are not the ones to go to, and somehow we have to lobby government or somehow get these different multidisciplinary silos to the table when it comes to preventing transmission. Doctors are not the ones we need to go to.
Yeah, I think though, Gabriel, there's some champions, there's some leaders, in the field that do understand airborne transmission, like Joe Vipon, for example, that are really you're rattling the cage. So I don't know if I agree with you there. And also, Lynn is an emergency doctor, and she's a great advocate for
No,
this.
I'm not saying there isn't somebody out there, but how many times have you heard her on the media compared to Fauci or compared to tip of my tongue, our doctors from downtown Ontario, downtown Toronto? These are not. There are some, of course, there are doctors. I mean, yes, but they're not being listened to. They're not. Those few aren't being heard. But the general statement that Heather said about the healthcare professionals. No, your family doctor is not the one who's going to know about how to stop transmission.
They should. They should be educated. We should educate each other. Anyway, Val, did you want to maybe do some closer comments, or anybody else want to share their thoughts? Lynn, before we've got about 5 minutes left. We can use it.
I think I took Gabor's comment is in general, and I think I agree. The only reason I know so much about aerosol is I signed up with an OCAL webinar years ago with Kim Prather, and you guys educated me, and I kept coming back. Most physicians are not taught about aerosol. And I was just rereading Jose Luis Jimenez, the history of how we got the 5 micron versus the 100 micron wrong, and where we went wrong in history, and the error got repeated. So I think overall physicians really do not get it, and it's sad. And I can tell you, having been a physician, it's very frustrating when you cannot help somebody And unfortunately, we default to, oh, it must not be real. And we did that with chronic Lyme. We did that with ME/CFS, and we're doing that now with long COVID. And it's a bad habit of when you don't understand and you've looked at everything, every test possible and imaginable, you don't go, what am I missing? If maybe there's not a test invented yet, maybe we don't have the science. You default to, it must be psychological. And it's completely ridiculous, but that's what we're seeing. We're just extending what we did with chronic Lyme, with ME/CFS, and now we're doing this with long COVID. And the magnitude of people affected is flabbergasting. And we're going to have more if we don't get this to spread through the air and stop washing your goddamn hands and clean the air and improve ventilation. And the reason I'm saying we've tried to go through public health and to government, and it doesn't work. So if you have a matrix, what I've been taught by Janice Stein in leadership is, if you can't use your direct level of hierarchy, then go around.
Mm-hmm.
And we're at the point where we need to go around public health. We need to go around provincial health, and we need to bend the ear of the fence to say, blast your message. You get it, but you got to blast it. It doesn't, they still don't deliver healthcare, but that's the only way I see it. And science, as much as I would like it to work, doesn't work. We need to follow Marshall Gans. So hit them with the heart, hit them with the mind, and then it's the hands and the feet. What are the concrete things they can do? And you got to pull the heartstring, because science alone does not work. We tried that with public health, and we tried that with the public in POP BC, and it has not worked. We need to lead with the heart. What do people care? And unfortunately, it's going to be different depending on who your audience is. But parents care about their kids, and they care about their kids getting diabetes, long COVID, and all sorts of things. Parents would chop off an arm for their kids. So that's where we need to go, and we need to make school safe in September. Otherwise, we're basically disabling an entire generation. That's all I have to say.
What a great ways to close. As always, we really appreciate your input, Lynn.
Yeah, thanks.
The emergency doc and understanding the science. Thanks again.
Yeah, thank you to Kevin, and thanks, Lynn. And in fact, we are planning to take a pause with our COVID probably next month, although we are cooking up, maybe that's a pun, a webinar on wildfire smoke and PM 2.5 particulate hazards indoors and outdoors, and many other workplaces besides those affected by smoke, probably on July 14th, and it'll be on our website and of course in our newsletter, and we'll do an COVID conversation about that. And then we'll be back in August talking about school safety, because we have seen from the CDC report of the 70% of household transmission started in school or was influenced by schools, as a huge impact on society, on workplaces. Schools are a workplace. And of course, children and youth are the future for all of us, actually, right? We all want there to be a viable future for our kids and our children's kids, and on all that sustainability, societal sustainability. So we're going to pick up the conversation again in August, and we really appreciate everybody coming today and staying the whole time and sharing your thoughts. We will be posting, this was broadcast on Facebook, so it'll be rendered as a video there immediately afterwards. It'll be available if you want to share it, and then it'll be posted next week on our YouTube channel, and we will post Kevin's slides. Dr. Viehbeck has said that she's not able to share her slides at this time, but if anybody has a request, I think we could make a direct request if anyone has any specific questions to her. Her office did say that she was willing to answer any other questions raised as well. So we will share the chat with her, as Dorothy suggested. And otherwise, I wish everybody a safe and healthy summer. And we'll see you next month, maybe, or in 2 months as we gear up again to try and prevent what's happening in Australia from happening here in the fall.
I see Kimberly's got a hand up, Val. Did you want to say something, Kimberly?
Oh, I just wanted to check, Val, I did check if Facebook Live was running. I'm not sure that got started today. I couldn't find it anyway, just to let you know.
Oh, it's interesting. It's showing us live, but I don't know if Tony's here. It's possible it's on an obscure. We have two accounts. So we will facilitate the
Perfect.
transfer to the other account if it's on the obscure one right now. Thanks for letting us know about that, Kimberly.
And if Tony could share the chat too with me later, that would be great, because I'd like to go through that if that's at all possible. Val.
Yep.
Thank you.
Thanks,
Kimberly.
everybody.
Thanks, Val. Thanks, everyone, for sticking around.
Thanks a lot, Lynn. And to
Thanks,
Liana, Gabor, and everybody else who spoke too. Thanks.
Thank
Bye-bye.
you so much.
Sure if I can. Tony, are you there? I think I have